Okay, so yeah, my name is Edgardo Rivera Lopez. Thanks you guys for having me today. It's a pleasure to present this case report today in this conference. I'm a physical therapist. This is more on the medical side case report from a college softball player. I did my doctorate. I'm from Puerto Rico originally. I did my doctorate in Puerto Rico and then finished my sport residency at University of Incarnate and D1 University in San Antonio, Texas. And now I'm actually the upper extremity fellow for the Toronto Blue Jays and UW Health. So that's where I'm at right now. And the case that I'm going to present today, and I report the abstract on it, is going to be a softball player, again, that I mentioned before, that happened in my residency in University of Incarnate Word. And it's a really interesting case because something like new for us, right? That is recent, like the COVID-19 changed the plan of care and the results of it and the outcomes in a college softball player. So it's gonna be I'm gonna try to be like pretty general in like PT wise. Like there's a lot of outcome measures there that probably not all the people know, right? But I'm gonna be like the most specific, but at the same time that everyone can understand. So this is the abstract that is going to be on the website. My objectives will be report considerations of the case, of the history and symptoms presentation, assess and identify impairments based on evaluation and examination in physical therapy, discuss important factors of plan of care decision-making, and possible factors that affect rehabilitation and performance, especially in this case. Oh, there you go. Let me close this in here. That's better. Okay, so first of all, starting, I like to use this SINS model because instead of just, asking pain or asking something specific related to MSK, it gives us a better model of contextual factors that can affect the rehabilitation any person. Like it doesn't need to be specific to sport, but in this case, it's an athlete. But it's basically a 20 years old female softball athlete that it was presented with chronic elbow pain that came to a clinic for eval, to the training room, basically. And she got this chronically for around 1 year, and she was up and down, doesn't get better, doesn't get worse. But at this point, she was getting worse when she came to me. And then at that point, 1 year ago, she was diagnosed with medial epicondylosis, and she got an MRI that was cleared at that point. But that was the diagnosis that she arrived with. And her most complaint was on the elbow, but at the same time, she was presenting symptoms going down to the hand, and at the same time around the shoulder and a little bit on the neck too. And then she has history of psychosocial factors like depression. The same time, the good part was she was working with a psychologic too, especially in a sport performance wise too. So that's something that I want to address early on the rehab, but at the same time, it's not my job, right? It's not my role. So, but make sure she was on track with that, because it was something chronic. So I want to make sure like she, like she was not like, hey, I'm ready to do rehab. I want to get better, but at the same time, like moderate motivation to complete the rehab. So that was something that we want to make sure we address early on the rehab. And then she presented with high severity pain, intermittent use of ibuprofen, and then she reported like a stabbing, shooting pain, numbness, and tingling down the first two fingers, most related to ulnar nerves, but also reporting coldness and swelling in the mornings that usually resolve like first 5 to 15 minutes in the morning, but also heaviness on the arm. Most of the stuff was reproduce and increase symptoms with softball activities, but also some daily activities like writing in the classroom or just carrying heavy stuff in the weight room, stuff like that. But then she, at the same time, she was working with the athletic trainer before, and she was having like light symptoms improving with manual therapy. And the nature of the symptoms, she was really apprehensive to movement, especially with softball activities, and had a lot of fear of getting worse with any activities that she was trying to do. And at the same time, she was showing symptoms of medial epicondylitis because of the pain, discomfort with the flexors in the wrist. But at the same time, my brain was going more on the neurogenic side because of the swelling, nerve symptoms, numbness, tingling going down. So in my first thought was like, hey, this might not be only medial epicondylitis. There's something more going on in here. So my first top three things was there's some ulnar nerve entrapment. There's some thoracic outlet syndrome could be here, or there's just medial epicondylalgia that could be related to. Let me close this in here. That could be related to just the pain that she was presenting and the history that she has. Then this is basically my top screening and mine that was going through the differential diagnosis. Just make sure ulnar nerves could be the like the neuro-like symptoms that she was feeling on the two fingers, the swelling on the elbow, sometimes it's presenting Tinel sign that is the test is specific for the ulnar nerve. She gets symptoms when you press the cubital tunnel where the ulnar nerve goes down to the arm. She has wrist strength weakness, and she has also flexor collineus syndrome that's right by the ulnar nerves test forearm. And also another ulnar nerve test was positive. So that's some of the things that drive me that way. But at the same time, she was reporting symptoms a little bit like cold sensation, heaviness, swelling that is more related to thoracic outlet syndrome. And then all the first rib, pec minor, and posterior scalene that are usually spot that you can increase symptoms and get you to the thoracic outlet syndrome diagnosis. And also the RUS test, that is another special test that we use for diagnosis thoracic outlet syndrome. By the other side, medial epicondylalgia was there, but mostly for the wrist flexor tenderness and painful, and monomuscle test, like the strength test, was a little bit painful too. But ulnar nerve are not common. There's some cases that you can have them, but they're not really common. And usually with rest and a lot of activity, the symptoms improves. And in her case, rest was not helping neither. So at that point, me as a physical therapy, I was like, hey, I don't think this is only, medial epicondylalgia. So I'm going to start to treat her like a thoracic outlet syndrome, all the symptoms she presented and all the stuff that she was basically positive and reproducing symptoms to. But at the same time, I want to give a little bit background to on the medical side, from the sport doctor and the surgeon. So X-rays and MRI were clear for medial epicondylalgia at that point in 2022. Ulnar nerve entrapment was cleared too with nerve conduction 10 and EMG. And then finally, the TOS results was diagnosed in January, starting January. But keep that in mind because I'm going to go a little bit back again to start to talk about like what happened before that actually diagnosis. So this is just another framework that I use to make sure that she's appropriate, or any athlete or any person is appropriate to physical therapy, or at that point I need referral, or if it's not appropriate and I need some other medical provider to get her treated. And at this point, she doesn't have any, she has shoulder origin symptoms, but also non-shoulder origin symptoms. And on my top of my head, it was more like a thoracic outlet syndrome, so I had that direction. And something I like to do really early in the rehab too is create some milestone for the athletes, so she's aware where we're going, what's the steps, and at the same time give her motivation to actually complete the rehab and have a goal every 2 weeks, 4 weeks, 3 weeks, depending on the timeline. And in this case, if we look in the research for TOS, usually 3 to 6 months is the outcomes to get better with rehabilitation with physical therapy. So that was the timeline in my head, but at the same time, I was able to see her at least 3 to 4 times a week. So hopefully getting more treatments and close with her, I will get better results. And all this stuff is basically, all these milestones are related to strength, external rotation strength, close kinetic chain, endurance of the shoulder. DASH is mostly related to shoulder function, and TSK is mostly related to kinesiophobia, to make sure we address anything on the shoulder, anything on the kinetic chain. and anything on the mental aspect too. The goals for the patient was basically to return to sport with no fear, avoidance and presence of pain with activities. And at the same time, she wanted to improve performance as a catcher, especially her throwing mechanics, that when we analyzed the videos before how she threw on her, all her career, we knew there was a factor that was increasing the symptoms and making her worse. So we want to work at that as soon as we can. But also talk with her about prognosis, right? Like, if it's actually good for her to do physical therapy at this point, or hey, surgery is an option right now. And then when you see the outcomes from surgery, depending on what research you read, is around 70 to 90% and a little bit lower in overhead athletes. And then some cases are reported after 36 months of the surgery to still have symptoms. And I will say pretty high number on complications reported, 7.85%. And then, but at the same time, these outcomes that you see here, they get better if they complete at least 4 to 6 months of rehabilitation, either before or after two. They're gonna need it both. So at this point, when we see the outcomes of physical therapy around 81%, in an average of 4.7 months, that's why my milestones was around 5 months to get her back. When you compare those, it's like, hey, most of the surgeons recommend 3 to 6 months of physical therapy before trying to do a surgery. So, and at the same time, if she doesn't get better with physical therapy, she's gonna have probably better results after the surgery, just because all the impairments that we work really early on the rehab. And basically, this was her progression to return to sports. Same thing, range of motion, grip strength, shoulder and elbow strength, ASH test that is mostly like a performance and fatigue readiness measurement. And then at the same time, we're trying to decrease and centralize the nerve symptoms and make sure they disappear or they're really localized. And then how can we assess function in daily in sports with the dash? And then make sure she doesn't have any fear to play or get injured. And then with the lower extremity assessment, make sure she got the full kinetic chain treated. So plan of care at that point, we start to address mobility deficit, we target motor control, we work on scapular stabilizers and shoulder strength. We focus more on endurance training just because of the nerve symptoms, instead of like trying to be heavy and 5 reps or 3 reps max or stuff like that to get really, really strong. Make sure we deal with the nerve symptoms first and swelling before we actually increase volume and intensity. And this is a simple progression that we go through the rehabilitation. The first thing I put in here, and I think is one of the most important thing for me, is the education of the pathophysiology. So the patient is aware where she's at, what's the prognosis, what's the goals that she's gonna achieve, and what's the result. So I think an informed decision making for a patient, whatever pathology you have, is really important to make sure they understand what's going on, and basically you're not hiding anything at the same time. So we work with dry needling, soft tissue mobilization, thoracic mobility, endurance. Diaphragmatic breathing was a game changer for her, especially early on the rehab. And then we progressed her around 8 to 14 weeks, with the break of Christmas to start hitting and throwing program. So the big thing is when she started to get almost ready to return to sport and get clear fully, around back in the end of November, starting December, she got COVID and she was down for 2 weeks. When she came back to me, she was basically about the same when we started in August, or even worse after COVID. So in my mind was like, what's going on? You know, we did not change any volume. We did not change anything on the rehab. You know, I started to think all about all the factors or variables that you can manage in this case. So she was even showing symptoms with the thoracic, and we start to think about T4 syndrome or stuff like that, or any CNS or PNS pathology going on. And the only thing that comes to my mind is like, hey, the only thing we changed in this pattern or this time was the COVID-19 that was in the middle. And then we knew that this is something new out there, and we don't have a lot of research on it. And in 2022, they published this research that talked about how COVID-19 can affect different systems of the body. And in this case, it's going to be mostly related to the neurological symptoms. And basically, they conclude in the neurological side that the COVID-19 can affect peripheral nervous system and CNS. And the theory that they explain is they suspect a route of invasion in the intranasal inoculation via the olfactory nerve into a CNS that can affect the symptoms, right? Or it can be also, it's been reported that the virus can spread in the neuronal cells along synapses and sometimes also in the brainstem. That could be related to her symptoms too. So I really don't know the full explanation because there's no full research on it, or there's nothing new in the 2024 or 23 that I have found to explain why she, you know, like this could be a reason, but it's not guaranteed that could be there. So I think that's what is what was interesting about her case, like how something simple in like an athlete that you're almost progressing and getting better and with a neurological pathology, it can just get worse the symptoms or never improve. And basically it was sad because around January after those symptoms that she came back, like she just decided to quit softball. And then I stay in contact with her, and she's doing decently well. She has some bad days, but at least ADLs wise, she's okay. But performance wise, she never make it. And we still don't know if it was actually a COVID or there was another specific reason. And something quickly here, learning outcomes and big challenges, for sure, the timeline recovery, all the psychological factors that she was having on this process. At the same time, learning how to work with all the other medical providers to make sure she get the best care. And at the same time, with all these challenges, trying to match the demands of a softball player, D1 college, that is pretty intense and a lot of volume in the week. But it was really interesting case, and I think hopefully later in the research we figure out more about this and make sure we don't have any issues later too with this. These are my reference, and any questions